Thank you for the nice introduction, and thank you for inviting me to speak here at your conference. Non-Arteritic Anterior Ischemic Optic Neuropathy, or NAION. As many of you know, it's the most common cause of unilateral optic neuropathy in older adults, and there's a number of important risk factors that we all ask these patients when they present with these kinds of problems. Most of these relate to vasculopathic risk factors, nocturnal hypotension, and also this disc at risk, which you can see here. This is the normal disc, normal size with a cup, and on the disc at risk, the disc is smaller, and that crowds the axons as they go through the optic nerve head. A lot of the information that we know about the demographics of ischemic optic neuropathy come from the Ischemic Optic Neuropathy Decompression trial, which was a multi-center study that was conducted in the United States in the 1990s, randomized, sponsored by the NEI, and it aimed to observe patients for about 2 years. One group observation and the other group receiving optic nerve decompression. This study provided important natural history about NAION. It was large and prospective, and had a standardized definition for NAION and evaluated patients within 2 weeks of symptom onset. But are patients here in India the same as the patients in the United States? Maybe in some ways. An interesting study published just a couple of years ago by Saxena actually looked at this. And although it was a small study, only 40 patients, it was case controlled, and the patients presented within 1 month of symptom onset as opposed to the 2 weeks in the decompression study. They were followed for 3 months, so not as long as the decompression study, but still it provided important baseline characteristics that we can try to compare to see are NAION patients here the same as those that are described in the decompression study. There's been a lot of studies that have looked at ischemic optic neuropathy over the years, and here's the Indian study. And what you'll see is that there's a number of things that are actually similar. The male to female ratio is always somewhere between sort of 0.5 and 0.6. The rates of hypertension and diabetes, these vasculopathic risk factors, are also similar. But one interesting differentiation is the age. And that's one thing that was actually mentioned, is that the patients in India are perhaps a little bit younger than the patients that are presenting in the West. Does this have to do with earlier onset of hypertension and diabetes? We don't know, but that is one interesting finding that came out of that study. We know, however, that regardless of where these patients are, they present with painless vision loss, usually upon awakening, related to nocturnal hypotension. The decompression study looked at the vision, the presenting vision of these patients, and found that a lot of these patients actually present with reasonable vision, greater than 20/60 or 6/19. The Saxena study looked at vision, measured vision a little bit differently, and instead provided a median baseline visual acuity that was 20/630 or 6/190, which in some ways sounds worse, but again, it's difficult to compare because it was presented in a different way. The decompression study looked at the mean deviation, which was about minus 18.6, and the Saxena study looked at the most common visual field defect, which was infranasal, and that's consistent with a lot of other studies that have been published. These are the classic findings that we look for in ischemic optic neuropathy. Initially, patients might have some mild disc edema, segmental swelling with splinter hemorrhages, various located cotton wool spots, as well as dilated capillaries. The superior segmental swelling eventually will progress to atrophy, and here that swelling led to superior atrophy, which corresponds to the classical inferior altitudinal defect that we talk about in ION. Quick word about Pseudo-Foster Kennedy, which is a syndrome where there's an old incidence of ischemic optic neuropathy resulting in optic nerve pallor, and then an acute event in the contralateral eye resulting in swelling. So the pathogenesis has to do with transient insufficiency of blood flow to the optic nerve, related to the posterior ciliary arteries and the peripapillary choroidal artery. And this is related, as we talked about, the vasculopathic risk factors of systemic microvascular disease, this crowded optic nerve head, and nocturnal hypotension. Hay-Ray studied the optic nerve head and found a number of interesting and important findings. One, that there's between 1 and 5 posterior ciliary arteries that are located around the optic nerve head, and these branch into long and short PCA. Importantly, there are watershed zones between these posterior ciliary arteries, and these watershed zones are what explain these segmental disc swelling. Hypoperfusion of the PCA. Most commonly, these watershed zones are located on the temporal and superior part of the disc. That's just how these blood vessels happen to be arranged, and that's why we get this generally superior disc swelling resulting in an inferior visual field defect. There's really not a lot of evidence for embolic or vaso-occlusive events, and so those have been mostly put to rest as a cause for ION. The natural history is that a fair number of patients, maybe about a third, will have some visual improvement over about 2 years after their event. But, about 20% may actually have worsening of vision by about 3 lines at 2 years. There's not a lot of change in the visual field over time. It's really the visual acuity that tends to change. And we know that patients with vasculopathic risk factors fared worse. Edema is a common question my residents ask, resolves in about 6 to 11 weeks. These patients tend to develop pallor but not cupping, which is a little bit different from arteritic ischemic optic neuropathy, which is more likely to develop cupping after time. Second eye involvement was also studied in a number of series, between 30 to 40% in some series, although the decompression study found it in only 15%. But still, that's an important thing to discuss with your patients as to why we have to control the risk factors to prevent second eye involvement. Sequential same-eye ION is actually not very common, and one of the reasons is we think that the atrophied part of the nerve allows a little bit more room for nerve swelling should there be a second ischemic event. The important systemic factors are transient ischemic TIA, stroke, and MI. And for that reason, any patient who presents with ischemic optic neuropathy should be referred to their primary care doctor for a full physical exam. A number of medicines have been looked at over the years to try to treat this condition, including neuroprotective agents, antithrombotic agents, vasodynamic medications. One quick word about vasodilators. We are already concerned about nocturnal hypotension and hypoperfusion of the nerve, and so these should probably not be considered at all in these types of patients. And other agents like erythropoietin, brimonidine, anti-VEGFs, hyperbaric oxygen. But the one thing that I do want to speak about in a little bit more detail is steroids. And I think a lot of us have considered and maybe even give steroids to patients with ischemic optic neuropathy. And one of the studies that is commonly cited as the reason for doing this is this study by Hay-Ray from 2008 that looked at the use of systemic corticosteroids. And the conclusion from this study was that both visual acuity and visual fields improved up to 6 months after the onset of these symptoms. However, we should take a little bit of caution because this was not level 1 evidence. It was in fact a patient choice study where the patient decided did they want steroids or not. There was no masking of the patient or physician. And when we looked at the patients in the study, there actually were more diabetics in the untreated group than the treated group. And therefore, did those patients do worse because they were sicker? Ultimately, I think there's a little bit concern for bias in this study, and we should be careful drawing conclusions based on this study in terms of the use of steroids. The decompression study, which we discussed about, provided important baseline characteristics that help us understand how these patients might fare, was really designed to study will this intervention help these patients and their vision? And it turns out that it was not effective or harmful. And this was determined at the interim analysis of the study. At the interim analysis, it was observed that the intervention was not effective because the patients who were observed ended up with better vision than the patients who had surgery. And in fact, maybe this intervention is harmful because the patients who observed were less likely to lose vision than the patients who had the surgical intervention. So at the interim analysis for this study, it was determined that this is not effective, may be harmful, and the study was stopped early. So to date, there's still no proven treatment. We tell our patients to manage the vasculopathic risk factors, evaluate for sleep apnea, but there is one ray of hope. There is an ongoing clinical trial that was partly based on that data that I showed earlier about 20% of patients who may have progressive vision loss. And there's some thought that there's a role of apoptosis that can cause this progression of vision loss. These patients have been found to have elevated caspase levels, and caspase is a known propagator of apoptosis. And so can we block this caspase and therefore prevent this further vision loss? And that's what this study aims to find out. This is a prospective randomized placebo-controlled multi-center study, 530 patients of an intravitreal injection of a caspase inhibitor to find out the proportion of patients who lose 15 letters or more of best corrected visual acuity. So this is the largest ION study to date, 8 countries, including India. Important referral criteria that you should consider are, all have to be patients aged 50 to 80 with sudden vision loss in the last 14 days. And this is one of the most important criteria, but also one of the things that limits some of the referrals, because a lot of physicians feel there's no treatment for ION, so they don't expedite the referral. But for this study, we have to think very carefully about that because they're excluded if they're after 14 days of symptom onset. And they cannot have had any prior treatment for this vision loss, including steroids and bromonidine. Those are both exclusionary. These are the 12 sites in India, which can also be found on this registry. In summary, ION is the most common cause of unilateral optic neuropathy in patients over 50. In India, patients may be a little bit younger than in the US. The pathophysiology is related to the watershed zones from the microvasculature. Remember the natural history, 30 to 40% will have visual improvement, but 20% may have worsening of vision. And because there's no proven treatment, there's a very important clinical trial ongoing. Please consider referring your patients. Thank you.
Thank you, Dr. Macintosh. If anybody is having any question regarding NAION, then they can ask from Dr. Macintosh or about the trial.
Yes. It was a fenestration, an optic nerve sheath fenestration. Thank you.
No.